Good afternoon, everybody. It's just on midday, and I'd like to welcome you to our smoking cessation professional webinars hosted through APSAT. We're very pleased today to have particularly well-known researchers in the field of smoking and pregnancy. I hope you can all hear us properly. You'll may not be aware that this is also being recorded, so you'll have access to this to send around to other colleagues to this presentation. Particularly well known is Gillian Gould. I'm sure many of you know of Gillian and her wonderful and remarkable work in smoking and pregnancy. Possibly Ratika may be a little less well known, but coming up as becoming increasingly around Australia well known on this topic as well. So we'll potentially start with Gillian, who's going to do her presentation first up, and then we'll move on to Ratika and her presentation. So take it away, Gillian, who's going to just announce a little bit about herself too before we start. Thanks, Gillian.
Thank you. Welcome, everyone. I'm really excited to be able to give this presentation today. So I'm an associate professor at the University of Newcastle, and I'm an NHMRC in Cancer Institute New South Wales into practice fellow, and I'm also a GP and a tobacco treatment specialist. I have been working with Aboriginal communities for the last 14 years, trying to develop better strategies for smoking cessation, and now particularly focusing on pregnancy. And just hand over to Ratika to introduce herself.
Hi everyone. I work with Gillian at University of Newcastle as a researcher. I have been trained as a dentist and a dental public health specialist. And since the last 5 years, I have been involved in smoking cessation research in vulnerable population. My research focus is health promotion and tobacco harm reduction in Aboriginal people, people living with mental illness, and those with alcohol and other drug disorders. And my particular interest is in e-cigarettes. Off to Gillian.
Thank you. So we'll just go on to our discussions. So we just have the next slide.
Can I just, while you start, Gillian, just to mention, for those who have got their speakers on, please turn your speakers off. And if you have a question to ask, please type it in rather than put on your speakers. So if there's a rebound sound, it's mostly because the speakers are on.
Yeah.
Thank you.
Okay, so we mentioned partly about how we're funded.
Can you hear me?
Sorry?
Somebody's speaker is on.
Also funded by Cancer Australia at Commonwealth Government.
You still can't hear? Have you got audio?
Liz, we can hear you.
You got speakers on your computer?
Liz Baxter, your speaker is on.
Because I'm like, sorry, I turned my audio on, and they could hear. But then I could hear them saying that they could hear reverberation, so I had to turn mine down. But yes, as soon as I turned my speaker on,
Liz, we need to have you turn your speaker off. I can't get her to turn it off. Go ahead, Gillian.
Now, yeah, okay. So just really funding's coming from major funders. Nothing. We don't take any money from the tobacco industry or e-cigarette industry. So there's no real conflicts of interest, and we just like to acknowledge the traditional owners of the land in Australia and pay our respects to elders past, present and future. I'm talking from a Wabakal country, and in Newcastle, and Ratika's in Orange talking from Wiradjuri country. Next one. So we'll just go over some of the basic stuff about the risks of smoking in pregnancy for women and their babies. So we do know smoking in pregnancy is one of the major risks that can affect women. Often people think about the effects on the babies, but the effects on women for themselves during their pregnancy and birthing effects are quite profound. So women are more likely to have spontaneous abortions. They can have ectopic pregnancies. They can get placental abruption, which obviously can affect the baby's outcomes as well. Placenta previa, causing bleeding problems. They can go into premature labour and have premature rupture of the membranes and have preterm births. So all of these are quite significant effects on the mother that can be prevented if she does stop smoking during pregnancy. Then when we come down to the risks for the baby, the fetus and the baby, so babies have a higher risk of being stillborn. They can have congenital heart defects. They have a low birth weight, and small for gestational age. And that's the one that women seem to know more about. They have heard that they can have a smaller baby if they smoke in pregnancy. But I think what we have to do is help women understand that means a smaller, sicker baby, not just easier birth. Babies can have a sudden unexplained death. And then there are things like going on into childhood, like an increased risk for childhood cancers, respiratory tract infections, asthma, ear, nose and throat infections like otitis media. Children can go on to have behavioural problems. And sorry, I don't know where that's coming from.
That's coming from me.
Some of the things that are not probably publicly known are things like ongoing sequelae leading into non-communicable diseases in the long term. Like, for example, a higher risk of obesity, a higher risk of, cardiovascular illnesses, ongoing chronic obstructive airways disease, and diabetes into adulthood. So these are really, really important and often not, people actually often don't know about those long-term effects. So I have the next slide. So then, there is also this similar effects from exposure to secondhand smoke and tobacco and nicotine in other forms. So we know there has been research about, and so when we talk about tobacco in other forms, that can be like smokeless tobacco use, like chewing tobacco, or use of a water pipe, for example, which might not be so common here, but certainly in other countries. So things like reduced fertility, reduced success for women going through assisted IVF, for example. Also commonly very similar low birth weight, preterm births, affecting babies' lung development, the same sort of things with spontaneous abortions and stillbirths, increased congenital heart defects. And, there is also the microscopic level precursors showing that in the fetal arterial wall, some of those babies will go on, why they go on to perhaps have some cardiovascular diseases later in life, because there are some evidence that happening in utero. So it is really important then when we think about exposure, we're not just thinking about smoking, that there are other kind of forms of exposure, and Ratika's going to talk a little bit more specifically about nicotine exposure later on. So how do we weigh this up? We know now there's about 7,000 different chemicals in tobacco smoke, and many, I think it's like over 60 are carcinogenic. So we know that it's not just the nicotine in there. Nicotine's one part of the story, but there's also all those other toxic chemicals, and the increased exposure to carbon monoxide has a deleterious effect in itself. So we know that that tobacco smoke does have a very, very serious effect on the mother and child, and we know that both from animal studies and human studies. When we come to looking at nicotine on its own, which is like one chemical, and is the chemical obviously that makes people addicted to smoking, most of those studies, in fact, all have come from animal studies. So, I mean, we don't have really good human level studies at the moment to look at how nicotine affects the baby. We do know from animal studies that nicotine can affect birth weight and cause some of those similar things like preterm birth, stillbirths, cognitive impairment, and impaired lung development. But up to now, the studies that we do have, which are from things like randomized controlled trials of using nicotine replacement therapy in pregnancy, there haven't been any increased risk of adverse effects from using NRT in pregnancy, look either on the mother or the child. So if looking at, but those studies, you know, they're not huge. I mean, I think it's only about like 2,000 women have been through randomized controlled trials of NRT in pregnancy. So obviously more research needs to be done to be able to say nicotine is completely safe. So how many women does this affect? And we're looking just really Australia and New Zealand here. So we know that the rates of smoking in pregnancy have definitely gone down over the years, and at the moment, you know, the latest figures are with 9.5% of pregnant women smoking in the first 20 weeks of pregnancy. But there are sort of more particular at-risk groups, and it's very similar, like with other, when we look at the other prevalences. So, you know, younger women are more likely to smoke, and definitely in rural and remote areas that the prevalence is higher. And particularly goes up in very remote areas. 34.6% women smoke in very remote areas. And then of concern is the 42% of Indigenous pregnant women that continue to smoke in pregnancy. And when we look at New Zealand, it's very similar. So overall, 13% of women smoking in pregnancy, but when there is obviously a gradient with the low women in low socioeconomic circumstances of smoke more, and 35% Maori women smoking in pregnancy, reasonably low levels in Pacifica women of 10%, but it is quite low when you look at just women of European descent. So this helps us focus on where do we need to put most of our efforts into helping people quit. So as I mentioned, being in low socioeconomic circumstances definitely increase your risk of smoking, but also the other people at risk are young women, women who had multi-parous, that means they've had, you know, multiple children altogether. If the partner's a smoker, if the family smoke, obviously it's hard to quit if everybody around you is smoking. We've mentioned Indigenous populations, but you know, one of the factors that we do need to understand with Indigenous populations that we won't have time to go into too much here, but you know, is that ongoing effect of colonisation and dispossession, racism, lack of access to services, stressful life circumstances. So there's a whole myriad of factors that do really cluster together with Indigenous pregnant women, which make it much more difficult to quit smoking. And then also highs women with other substance use in pregnancy and mental health clients. So, you know, we need to take all of these things into consideration clinically as well. So when, you know, a woman gets pregnant, some women do, you know, quit as soon as they find out they're pregnant, or as I mean, sometimes that actually is influenced by nausea in pregnancy, because one of the things when women go off their cigarettes because they feel sick, and the smell can actually aggravate that nausea. So we find that about 47% of women do stop smoking in pregnancy, but there's this other 53% of women that carry on smoking. So that, you know, that's something we really need to focus in on when, you know, that's not a small proportion. So it's important that if women don't, you know, spontaneously quit when they find out they're pregnant, that we do make sure we're asking and assisting these women to quit smoking. So why are women not able to stop smoking in pregnancy? So there's a few things happening. So, you know, there is a profound influence from the family and social network. So if you're hanging around with other smokers, if other people are smoking in the family, it does make it that much harder to quit. We also know that health providers are not necessarily providing the right sort of advice, are very reticent often to tackle this more complicated area. So, you know, I will cover how women often being given mixed messages about quitting in pregnancy. And we know health providers are not feeling very confident in this area, that they don't know what to advise about nicotine replacement therapy. They're sometimes not optimistic that people are going to quit smoking. Coupled with that, we have the higher metabolism. So just go back one slide, Ratika, the higher metabolism. So because of the increased metabolism overall in pregnancy, and it's faster, that women metabolize nicotine at a faster rate. And what happens with that is they actually can want to smoke more in pregnancy. And if you don't ask women, you know, are you smoking more or less or the same? Women are not going to actually tell you they smoke more. They're not going to volunteer that information. And because women are trying, often are conscious of the fact that smoking isn't good and try to reduce, they often then are quite distressed and having a lot of cravings, which they may interpret as stress. So to them, those withdrawal symptoms, it makes them feel like they're stressed and there's something wrong with them. They need to keep smoking because they're stressed, not understanding that really their metabolism's increased, and that's kind of really driving this these urges to smoke. Coupled, you know, and that's where you got that link across with all of those anxiety symptoms and withdrawal symptoms there on the left. So what are we supposed to do? So what are the guidelines telling us? Well, first of all, the guidelines vary a lot. So depending on what professional college you belong to, the guidelines are somewhat different, whether you're, for example, an obstetrician or a midwife or a GP. So the RACGP guidelines say that women, you know, should ideally have an unassisted quit attempt, cold turkey, so to speak, but have behavioural interventions as the first line approach. And then if women are not able to quit smoking in that way, then nicotine replacement therapy should be added. But, you know, how long, the question mark is, how long should they go on and try with an unassisted attempt? Because we have to think about, you know, we don't want women to lose impulse in their motivation with their quit attempt. So, and some women have actually already tried, by the time they see you, they're already trying to quit smoking. But this is what we're told to do, you know, and then nicotine replacement therapy is best to use the oral forms first, but you can use combined therapy by adding a patch. Now, at the moment, current thinking is that varenicline and bupropion are not recommended in pregnancy, and that's because of the lack of data about their safety. But there are some studies, hopefully will be published soon about that in Australia. So more to come on that topic. But when we look at actually what are we doing as health providers, so this is from a systematic review that I led in 10 countries globally to ask what components of smoking cessation care are health providers implementing during pregnancy. And this is reporting often and always. So like they're doing this at least 50% of the time. And we can see that we're quite good now at asking and advising women to quit smoking in pregnancy. But then there's a bit of a slippery slope goes down as we do less and less as we go down the 5 A's. So, you know, we may assess women, you know, assess their motivation. But once we come down to a starting.
So I will be talking about obtaining nicotine from a reduced harm product. There are two main reduced harm products I'm going to talk about. One is nicotine replacement therapy, and the other is vaporized nicotine products. The whole premise of using clean nicotine is based in the fact that people smoke for nicotine, but they die from the tar. So that's what Gillian just told us. So the two clean nicotine options, which is available to us, is NRT and the vaporized nicotine products. The first one, nicotine replacement therapy, most of us know about it. Both of these therapies have been tested to some extent for smoking cessation, but less so for the vaporized nicotine products or the e-cigarettes. So when we talk about harm reduction, we are conjecturing about switching to one of these therapies long term, that is using them as a source of nicotine as opposed to using cigarettes, which is the dirty nicotine, so as to say. NRT, as most of us are aware, are nicotine replacement therapies which are approved smoking cessation medication in Australia as well as the whole world. So they come in various forms: patches, inhaler, gum, spray, etc. They're broadly classified into two forms, the sustained release forms and the quick release forms. So the sustained release forms are patches, which when applied onto the skin, releases nicotine into the bloodstream, which goes to work them. The other forms are quick release NRTs, there's the gum, lozenges, inhaler, sprays. They are quick release, so they are mostly oral forms of NRT, and when chewed or sprayed into the mouth, they release NRT into the bloodstream through the oral mucosa. Both sustained release and the quick release NRT should ideally be used in conjunction to maintain an optimal amount of nicotine in the blood. So just as Gillian was talking about the risk versus benefit of the nicotine in women, we should also consider the risk is to benefit profile before we talk about using clean nicotine options as a long-term option in pregnant women. So there have been many animal studies which have shown that nicotine may cause low birth weight, preterm birth, stillbirth, and cognitive impairment in the fetus. But all these studies have been in non-human samples. We can't really extrapolate these findings to humans. We don't know if the same effects are present in humans as well. There have been studies where nicotine replacement therapy has been used in pregnant women, about 2,000 women, which has not shown any positive or negative birth outcomes in the children or the women. A recent meta-analysis and systematic review, it showed that women who are using NRT, they are actually exposed to less nicotine when compared to smoking. So all this research shows that if you're obtaining nicotine from an NRT product, it might be more beneficial than just keep exposing a pregnant woman to continued smoking. So even if you are considering taking nicotine replacement therapy as a long-term option, it might be beneficial in the long term as well. So what needs to be done to make NRT use truly successful as a tobacco harm reduction option? So one of the most common problems with the use of NRT is that people don't take enough of it, and they don't take it often enough. So they don't take it long enough for NRT to show its effect. So first thing which should be done is to titrate NRT to cravings to prevent nicotine withdrawal in pregnant women. The dose recommendations can be higher as nicotine metabolism is higher in pregnancy, and so higher than usual doses need to be considered. And it's also very important that combination therapy is used, that is sustained therapy, sustained release NRT options be used with oral forms of NRT, so that cravings induced by triggers are also taken care of, such as most of the people who smoke, they are triggered by visions of smoke or when they're having a coffee. So in those situations, the oral forms of NRT come into play, while all the background all the background craving should be taken care by the patch or the sustained release options. So usually when we recommend a patch, it should be high dose in pregnant women, and it should be 16-hour patch so that the fetus is not exposed to a sustained release of nicotine throughout the night. There are patches also, 24-hour patches also, but they're usually not recommended in pregnant women. And it should be of higher dose, so 25 milligrams. Even if we are using the oral NRTs, it should be 4 milligrams. What is the evidence base for using vaporized nicotine products or e-cigarettes? I know that this is a very contentious topic for most of us in public health. So I'll just review the evidence base for vaporized nicotine products in general population. So recently, a large study was done among 886 participants, which compared NRT and e-cigarettes for smoking cessation. And what they found was that almost double of the participants quit in e-cigarette group. 18% quit in the e-cigarette group compared to only 9% in the NRT group. Both groups had received behavioral therapy. So, and among those who had achieved abstinence, about 80% in the e-cigarette group was still using the e-cigarette at 1 year, compared to only 9% in the NRT group. What this signifies is that e-cigarettes are good when one is looking to switch to cleaner sources of nicotine long term, compared to complete quitting, which seems to be better in the NRT group. So people who were using NRT, they quit all the nicotine, compared to the people who were on e-cigarettes. They were using it for longer term, they had quit the cigarettes, but they were still using it after 1 year. So this has to be taken into consideration when considering whether to switch to nicotine replacement therapy or to the e-cigarettes. So what is the status of nicotine vaporizing products in Australia? It is legal to use vaporized nicotine in Australia if prescribed by an Australian doctor. But you can't buy or sell nicotine in Australia for use in nicotine vaporizers. So it has to be imported from abroad. About 1.2% of Australian adults used a vaporizer in 2016. This was from a National Drug Strategy Household Survey, and it was among people who are 14 years and older. Most of the position statements of peak public health bodies and medical bodies, they do not consider e-cigarettes risk-free. So the opinions don't really vary much when it comes to peak bodies. Most of them don't recommend e-cigarettes. ATHRA, which is the peak Australian advocating body for legalizing vaping in Australia, does not recommend vaping in pregnancy on their website. But at the same time, they state that it might be much less harmful than smoking in pregnant women. So what is the status of vaping in New Zealand? So it is completely opposite to that, what is in Australia. It is legally advised for quitting smoking in New Zealand, but with appropriate warnings. So the warnings are the best thing you can do for your health is to quit smoking. Then it is not for young children or young people, and it's not harmless. So all the warnings are there, but still it is legal to vape and buy and sell vaping products in New Zealand. The ban on smoking doesn't apply to vaping. So the indoor workplace ban and early childhood care centers and school does not apply to vaping products. So there has been very few studies about vaping in pregnancy. So some of the research is reviewed here. So one of the research from US suggests that 14% of the women enrolled in an RCT evaluating nicotine inhalator had ever used e-cigarettes. So it was a nested study in an RCT in which they found that 40% of the women who were enrolled, they had used e-cigarettes in the past. And what they found was that women who were more who had made more quit attempts, they were more likely to have used e-cigarettes. Also, although it was not statistically significant, women who were depressed or who had anxiety, they were more likely to have used e-cigarettes in the past. So in my opinion, women who are more addicted to cigarettes, more addicted to smoking, were more likely to have used e-cigarettes in the past. Another observational study of 74 pregnant women who had used e-cigarettes in the past 30 days, they found no relationship with cessation outcomes at follow-up. It's a really recent study, but there were some problems with obviously with the observational study design and other things, which I'll talk about later. Another recent study found that most of the women pregnant women who had used e-cigarettes, they did so to stop smoking out of curiosity, and what they thought was that they had perceptions which were that e-cigarettes are less harmful for mother and baby compared to smoking cigarettes. So what is the problem with this evidence? Firstly, it is very scarce. So there are very few studies, very little is known. And most of the studies are from animal and in vitro studies about vaping. Then the sample size have been very limited, which leads to inconclusive evidence of. Most of the studies do not collect the extent to which the e-cigarette used, the frequency and duration of use of e-cigarettes, which have led to unreliable estimates. So, no RCT among pregnant women has been completed, but ongoing. There's one multi-centric study which is still ongoing in the UK, and we, in coming future, I think in the next 2 years, we'll know the results. But even if we don't have enough evidence about e-cigarettes, about its harms and benefits, there are some things which should be considered if, as a health practitioner, we find a woman wants to start vaping, or they just ask us about vaping. So they may be more acceptable than NRT because of the social behavioral resemblance, such as hand-to-mouth action, visible vapor, and associated rituals. And they can be used for social and cultural benefits, so socializing and getting emotional support. This is especially true for people who have a smoking environment. So women who live in smoking environments, whose friends and family are smoking, they might need that kind of ritual to gel with them, and they might need that kind of support when they're pregnant, especially. So pregnant women who want to vape or want to switch to e-cigarettes must be provided with currently recognized pros and cons of its use so that they can make an informed decision about its use. The first option should definitely be NRT or a cold turkey approach, but if somebody wants to do it, they have read about it, or they have seen it somebody else doing it, they must be informed by the health practitioners about its pros and cons. So in a study with Gillian did, we were looking, they looked at how many practitioners were asking women about their use of e-cigarettes. They found that only about 13 to 14% of health practitioners ask about e-cigarette use among pregnant women, which means that it would be difficult to provide any advice about harm reduction without knowing the status of e-cigarette use among women. So currently, there are about 1.2% of adults using e-cigarettes in Australia. Regular asking and assessing of the use of e-cigarettes might lead to better advice and behavioral support to pregnant women who are using e-cigarettes that could help them eventually quit using one method or the other. So another very, very less researched field is supplementation with antioxidants. So this has been this research has been really scarce in this field. So it has been found that smokers have higher free radicals in their blood, which can lead to several chronic diseases such as atherosclerosis, cancer, neurodegenerative diseases, Parkinsonism, Alzheimer's disease. And these free radicals can also lead to adverse pregnancy outcomes like infertility, miscarriage, preeclampsia, fetal growth restriction, etc. And at the same time, in smokers, there is a depletion in vitamin C and E. Those are major antioxidants which are found in the body, and these neutralize free radicals. So these are depleted in smokers and radicals are present in more amount. It makes sense that supplementing with these vitamins in pregnancy might lead to better outcomes. There has been some research. I could find 2 studies. So in one of the studies, they looked at supplementation with vitamin C, and they saw that incidence of wheezing in children through 1 year of age significantly decreased in the intervention group, which was given vitamin C. In another study, prenatal vitamin C and E supplementation showed that it was protective for placental abruption in smokers. So we don't have much research, but there are studies planned which I know of, and hopefully we'll get more results in the future if it is a viable option to supplement with vitamins in women for harm reduction in smokers. Off to Gillian.
Okay, so sorry I dropped out.
Fine.
Dropped out before.
Should I go back?
Yes, I wasn't sure if you'd covered those slides. Sorry.
No.
Okay, so I think we finished with that one. We'll go on to the next one. So look, just going back to the principle of harm reduction. So, I mean, this has come out of the addiction and drug control literature, which started in the USA, UK, and Netherlands. So, harm reduction is when we think about harm reduction, we're looking at interventions, programs, and policies that reduce the health burden and social and economic harms of drug use to individuals, communities, and societies. So I think it's something that we can't avoid in the tobacco world. I think it's really important. But what is interesting is when we're applying this now in this discussion to pregnancy, where it's not quite so straightforward, because obviously you've got not only the mother as an adult, but you've got the baby, the considerations with the baby. And this is why Ratika and I are particularly interested in this topic. So we'll go on to the next slide. So the things that we were hoping to cover in this talk, and we're doing a little bit backwards now. So Ratika's already covered the looking at obtaining nicotine from a reduced harm product with the e-cigarettes and NRT, and supplement with antioxidants. But the other 2 ways that are commonly looked at are actually cutting down in pregnancy, reducing the amount of consumption, and reducing that exposure to environmental tobacco smoke. So these are 4 topics that we did cover in our paper that we had published this year in JAMA Pediatrics, which we've got the citation there. And if you want more detail on this, I suggest the paper should be accessible and have a look at that. So we know a lot of women do cut down in pregnancy, but the question is that actually helpful or not? We know drastic reductions in consumption may improve birth outcomes. And for some women, that can be a step towards complete quitting. But the other thing that does happen is this can be offset by compensatory smoking. So what that means is that when you try and reduce the number of cigarettes you smoke per day, the topography of the way those cigarettes are smoked means that often each puff is inhaled deeper, might be held for just microseconds longer in the lungs. So we do know that as humans, we try and keep the nicotine level, smokers keep the nicotine level stable at a certain level. So tend to be that if you go down from, say, 20 cigarettes to 5 cigarettes a day, you may be actually drawing back more on those cigarettes, and this is called compensatory smoking. And as a result, you might be getting as many toxins and just as much as carbon monoxide. We also know that when we put women on NRT, they may not be using that to the full extent. So we know that women take it less frequently than prescribed, and they are less likely to adhere to NRT for the full course. They might take it for a month and then they think they can manage without, or they're worried about taking NRT in pregnancy and then they relapse to smoking. And we know that health providers sometimes say to women, look, it's okay just to cut down. We still hear stories from women where the health provider said it's far too stressful for the baby for you to quit smoking. You are better off carrying on smoking. And we do have people who say, have heard health providers say, it's actually more dangerous to take NRT than continuing to smoke. And this is not like just years ago. This is like right now. So we know that health providers also don't want to push that quitting message because they're worried that's going to upset their relationship with the pregnant woman and maybe she won't come back to visit them anymore. So women are receiving these mixed messages. So just a couple of quotes. Ratika and I are just hopefully going to be publishing soon a qualitative systematic review that we've conducted over 10 countries globally. And just some of the quotes that came up from that, from those papers in that review. So I advised this patient to see her GP for patches or gum, but her doctor told her that to use replacement products would be more dangerous than smoking. So he said, either keep smoking or do cold turkey, so I don't bother now. And this was from a health visitor. And another quote, more recent, I think that if the woman gets too much stressed about the fact that it's forbidden to smoke, then the only thing you can say is, all right, you can smoke a few cigarettes a day. So this is the type of messages that we commonly, over the whole world, these are the things that are being told to women. So they're not being given a clear message that the most important thing is to quit smoking, and we can help you with that with the behavioural interventions and with nicotine replacement therapy. So when we also look at environmental tobacco smoke, as we went through at the beginning, that still has a very significant effect on the outcomes for both the mother and child. And, it's something that, it should be easier to remediate than even quitting. So this is sources of tobacco smoke other than smoking by the pregnant woman herself. For example, with her family, friends, peers, and partners. And this directly affects the health of the pregnant woman through inhaling that smoke. And it also then affects her fetus through going through the placenta. And it indirectly also makes it very hard for the woman to quit. If she's still smelling that smoke, particularly if it's smoking inside the home, then it also isolates her, because to actually keep away from that, she either has to step away and then be on her own, and might be the only person not smoking. So she can feel very unsupported at a very vulnerable time of life. So this is something that we need to think about, extending our counselling not only to the pregnant woman but also to her family members, so that we can have that discussion about how the household can better manage smoking so the woman is not exposed. So what's the evidence with interventions? So they do, behavioural interventions do appear to be effective in reducing environmental tobacco smoke. The problem is that most of this research, it relies on self-report. So there's very little research where they've used, say, for example, particle monitors in the home to get that objective evidence of actually smoking now being reduced in the home. and to be able to then do a pre and post, looking at the differences with that objective measure. And often these studies have had weak study design, and might have had no control group or very limited follow-up, for example. So we're not having really firm conclusions about whether those interventions are successful more on the population level and public health level. But certainly it's something that, you know, as health practitioners, that we can actually, we should be asking that. And if you recall the slide where Ratika showed how often we're asking, we're not also very good at asking about secondhand smoke. It's much less often asked about than smoking from the woman herself. So some promising approaches maybe in the future, looking at family and community-centred interventions to reduce exposure to environmental tobacco smoke in family units and the broader community, supporting partners to quit themselves, but also supporting them to actually help support the pregnant woman to quit smoking, and limiting those smoking to outdoor areas, and not just necessarily on the veranda, but having that good distance, you know, 5 meters from the doorways and windows is important. And then looking at maybe affordable particle monitors. You can get some of these quite cheaply, and whether this can actually help people in their homes monitor how that smoking you know, bans in the home is going, so that they can actually self-monitor that, and that might help them enforce the rules. Because sometimes in some communities where smoking is very prevalent, it's actually can be quite hard to enforce that home smoking ban. When you have family members come over that smoke, even if your own household doesn't smoke, some people need actually help to actually navigate those relationships so that there isn't a relationship breakdown. So just coming on to some recommendations now from the clinical point of view. What's really important is that we do have very clear messages to pregnant women who smoke that quitting is the ideal, that it's not just enough to cut down. And sometimes when we overly get excited about women cut down, the message they get from us is, I've done something really good, my health provider's very happy with me, and they don't actually get that message, hear that message, no, actually quitting is the most important thing. So, you know, I think we can, yes, celebrate any success with women, but just really have upfront in our advice that it's always clear the best results are going to be if that woman quits, and we can assist her to do that. We need to offer all women assistance. Not enough women are actually being assisted. It's not enough just to ask and advise. We have to go that step further. There's lots of behavioural ways that we can help women quit, with a quit plan, helping them make a quit date, talking through some of those triggers for smoking, problem solving some of those situations, for example. They don't necessarily need to take that long, but we need to, you know, be prepared to actually offer that assistance, and then be prepared to provide or prescribe the nicotine replacement therapy in sufficient dosage, as Ratika went through. Having that risk-benefit conversation with women is important, you know, to get it in perspective, because using nicotine replacement therapy is, I think it's generally an expert consensus. It's better to use NRT than continuing to smoke in pregnancy. And, you know, and depending on your comfort level with e-cigarettes, I mean, we don't have that evidence yet with e-cigarettes. We don't know with e-cigarettes what sort of dosage or extra contaminants they are having. And, you know, if we're not providing that message to women about NRT, that they can use NRT, they're probably going to be likely to want to experiment with e-cigarettes. but they should really give NRT a good go first. And we should be able to provide that advice to women and help them titrate that dose so that they're comfortable and not getting withdrawal effects. We do find that those higher doses are going to be needed because of the metabolism. But accompanied by behaviour change techniques. NRT should be used for a whole course of 12 weeks. Some women might need it throughout the whole pregnancy. And just a consideration is like the use of the CO meter, which really is also a policy recommendation, is thinking about using that CO meter to screen women before we ask the question. So then now what's being used in the UK is there's an opt-out rather than opt-in to smoking cessation counselling. So if the woman has a high CO reading, that one would progress with that counselling or referral for counselling to the quit line rather than, so that's like just standard care. And that has helped in the UK with more women actually availing themselves of help for quitting.
Gillian, can we have a few minutes for questions, please?
Sure.
We've got a couple of questions. First question, if you don't mind, was from Karen Counter, who asked whether Indigenous people have a faster nicotine metabolism rate like the Eastern Mediterranean people that we've studied ourselves. So do you have any
I don't think there's been any studies
perceptions on that? No.
No, I mean, that would be interesting to look at, and but I don't know of any research that's been done looking at the metabolism or genetic makeup of Aboriginal people.
Yes, and it's easy enough to do, isn't it? I mean, you can today not do the genes themselves, but do urinalysis of cotinine and 3-hydroxycotinine and look at that ratio. So it's actually rather easy to do if people are willing to give a urine sample. And I know that's very complicated and contentious in some groups. Amy's got just a comment saying how much misinformation there is out there, and we should have a media campaign about that. That is true. On our chat, we've got Wilson asking about.
Could I just address the media campaign?
Sorry.
Can I address about the media campaign?
Sure, of course.
So I've got funding from the Commonwealth Department of Health. Particularly, this is to do with Aboriginal and Torres Strait Islander women smoking in pregnancy, where we're going to be doing a social media campaign for women, but also as part of that, we're going to do a social media campaign for the health provider to actually get over some of this reticence that people have about not having enough time, not being optimistic that they're going to help. So we actually are planning to develop a campaign in that way next year. Yeah.
Thank you very much. Wilson asked about relapse, acute relapse. We know that quitting is pretty good, not great during pregnancy, but it's this prodigious relapse on the day. And I think that's a very good and interesting topic to study. Why do people relapse literally on the day, postpartum?
Yeah, I mean, yeah, and I agree that a lot of people, I think it's just this lack of the restrictive environment. It's a bit like, you can, when you're on an airplane, you can manage your withdrawal effects because, you can't smoke. As soon as you get off that plane, you have one. And I think that might be the sort of thing happening in pregnancy. But I think there are some other, women, for lots of reasons, I think they deserve a treat. They'll just have one, but then it does lead to relapse. We are, in our own group, we've got a PhD student whose topic is going to be relapse. This is again with Indigenous women, but it's something that really does need, there hasn't been a lot of research on successful relapse prevention tools. There has been some, we do know that some educational tools throughout pregnancy, preparing women that this could be an issue as they go along in pregnancy, does actually produce a successful result. And I think it's certainly because most of our messages are baby-centered, all about the baby all the way through.
Mm.
I think as you go on and start seeing women later in pregnancy who've been successful, is turn that around to be more about the woman herself. You know, what's in it for you, yourself, if you maintain that abstinence, you know, prepare the woman that she might, you know, be likely to relapse as soon as she's had the baby. But if we start talking about that later in pregnancy, and start the woman to think about, well, now what's in it for me if I stay quit? I think this is where it would be, we definitely need a lot more evidence and studies on that. But from a clinical point of view, it's worth having that conversation.
Gillian, have you seen those studies on hormonal effects acutely postpartum? And actually, there are good steroid studies, literally, as a response because of what happens on the day, literally, of birth. Things change with the mother hormonally. And there have been some thoughts around that, maybe giving the mum estrogen, or I'm not sure if you've seen that, preventing relapse on the day.
Yeah, I haven't seen any interventions, but I'm not sure whether it's the estrogen or the progesterone.
Progesterone, that's right. But what makes really good, it makes good sense, doesn't it? I think.
Yeah, well,
because it happens so acutely. It's not just mum gets these incredible urges to smoke so acutely, and the relapse is so acute that I've just wondered about whether these hormone differences make such a could be a treatment in itself to prevent relapse postpartum,
or just maybe even also boosting up the NRT is, like, you know, preempting that woman might need a bit more NRT on board.
We've got a question about America is implementing smoke-free public housing policies in Australia. Are we likely to do that? Does anybody? I certainly have a response to that. I'm not sure whether you do. Does anybody know about?
I thought there were some things going on, but Renee, if you know more detail about that, I'm happy for you to answer that.
Oh no, I just happen to know that the quit smoking groups in Australia are certainly moving towards that, and in not just in public housing, but related to all apartment buildings, and passive smoking in apartment buildings has become an issue that people are addressing too, and I think that maybe that will come about sooner rather than later. Any comment again from the group that on vaping for concurrent cannabis use in pregnancy? Anybody commenting on vaping for concurrent cannabis use? Ratika?
Vaping with cannabis, or
vaping with cannabis, or maybe vaping for cannabis. You have to unmute cannabis. Ratika, can you unmute your? Thank you.
Yeah, sorry, I'm not sure whether the question is about vaping cannabis or vaping tobacco, like using tobacco in conjunction with cannabis in pregnancy. So I would definitely not advise vaping cannabis.
Definitely not.
No. So that is a no-no. But if a person wants to vape, if they are mixing tobacco and cannabis and they want to quit tobacco, which was mixed in cannabis, so they can certainly try.
As harm reduction.
Yeah, I don't know.
No.
Cannabis is not a field of research, so I can't.
Yes.
But I would not advise it.
Can I make a comment just generally, if that's appropriate? I'd like to say something about vaping generally, and I don't believe, as probably most of you know, that nicotine is benign, and I certainly don't believe it's benign, the shot. So the difference between NRT and the patch, as I'm sure we all know, is it's low dose and it's slow release. Whereas nicotine in the vaping forms, and that's the whole issue here, when you vape it, you inhale it, it goes through into your arterial blood. I'm sure you know that. And these newer products, the more we produce these newer products of vaping, the better technically they have become. And therefore my view is that they are very much more dependence producing. And this inhalation of it, unfortunately, gives a bolus of nicotine that I'm afraid is not benign to the brain of the developing bub. I've got some evidence for that, and I would like to it depends on our audience today. If they'd like to hear this in a forthcoming webinar, I don't believe nicotine is benign. I do think it upregulates receptors in this format. Patches don't. We don't have a patch addict on the planet, unlike what you presented of Peter Hayek's work, where at the end of 1 year, people are still using these cigarettes. We expected that, right? They're still addicted to nicotine, correct?
Yes.
So they're not.
They're off cigarettes.
They're off cigarettes, but they're still addicted to nicotine. If patches, because of the slowness of their delivery, and this is my particular concern, it's so slow that really we don't, as I said, I've never, being the editor-in-chief of this journal from the UK, we've never seen a patch addict on the planet. So people don't get really addicted to patches, they don't get withdrawals from patches. If they leave them on long enough, it helps people enormously, and I've got no conflicts of interest, as you all know. So I'm very concerned about the neurological effects of these fast deliverers, and the faster they get, the more addictive they get. So that's the dilemma, and that does something to the baby's neurons as well. And I'd be happy if you were all interested in this, doing a presentation on this. Ratika, there's one other comment, if you don't mind me making, and that you said hand to mouth. You mentioned hand to mouth.
Sorry?
Oh no, it sounds right. Everybody thinks this is a good, analog for smoking, but there's actually not a lot of evidence for the whole hand to mouth story. I mean, evidence. We're talking evidence based all the time.
We have a lot of qualitative research about this.
Yes, but it doesn't get a lot of publication. I'd love to see more publication on, does it really matter?
There are actually a lot of publications. I did a study in
Did you?
Found, yes. So people are addicted to that.
I'd like to see.
They want to have something in their hands.
In their hands?
Yeah, hands, and they want something to do with their hands. So I have read a lot of research. If you want, I can send you the paper.
I would love to see more on this, because in all honesty, when I look it up, I don't find a lot.
Okay.
I mean, what sort of study can you do that replicates this or not?
Yeah,
I think it's anecdotal, and I'd like to see more material on it. Thank you for, if you want to send it to me and our colleagues, it would be really important, I think, to look further at this.
It is something that we have been called for with Aboriginal pregnant women who've asked for, this whole issue of wanting something to do with their hands. And we're doing an app at the moment, which is multi-behavioural around, which does include smoking and pregnancy. It's got colouring in. We've got a really good colouring in feature, so women can actually do combined mindfulness activity using their hands to do something pretty and colourful. So it'd be interesting to see what feedback we get on that, whether that kind of restlessness that people get when they're willing to take their mind off and do something practical.
Frankly, the reason why I talk about this a lot, about the hand-to-mouth discussion, is because when we use, not in pregnancy, but when we use varenicline, Champix, we see people just, I'm hoping you'll all have seen people like this, who simply forget to smoke. They don't have an alternative. They don't have anything else in their hands. They've simply just, oh, gosh, it's been 5 hours since I've had a cigarette. It didn't occur to me to use a pen or simulating the smoking. It just didn't occur to them to smoke. They literally forget to smoke. So I quite honestly can say that in clinical practice, I don't see a lot of people say, I missed this part of it. I don't see this a lot clinically. And I have, as I said, that's why I'm on this particular case of show me a bit more hard evidence for the hand-to-mouth assumptions. I'd like to have a bit more. I'm sorry to say this, but I think we've got to go now. We've had a really great audience, and I thank you really very much, both of you, for this. presentations, I think there's a lot of discussion. There's more about estrogen in the postpartum period, and I suggest that you all have a good look at what evidence there is around some of this.